Is very good.
So good evening, everyone. Today's topic for discussion is vitreomacular traction. First of all, history of VMT. In 1953, Irwin had described the vitreous-tuck syndrome in the cases in the vitreous strands were adherent to the cataract injection sites. In 1967, Jaffe described the vitreoretinal traction syndrome as a different hereditary differentiating from the Irwin syndrome. It was in 1967 only that Rees et al. Studied the macular changes in VMT and reported Irwin's and Jeff's description as a part of the same spectrum of the disease. He also was the one who confirmed the histopathological studies on vitreomacular traction syndrome. The anatomy of vitreous. Vitreous fills the space between the lens and the ciliary body anteriorly and the lens in the retina posteriorly. It occupies 80% of the eye volume. The vitreous body consists of the central core vitreous and the peripheral cortical vitreous. The posterior peripheral cortical vitreous is around 100 to 300 micron in thickness. It is composed of 98% of water and 2% of proteins and extracellular matrix. Collagen forms the major structure protein of the vitreous with the predominance of type 2 collagen amounting to 75%. The other is type 9 collagen. The proteins found in the vitreous are hyaluronone, chondroitin sulfate, fibrillin, and opticin. Vitreous has some physiological and pathological strong attachments to the retina. The physiological being the vitreous base, optic nerve, macula, and major retinal vessel. The vitreoretinal interface. The vitreoretinal interface is a complex anatomical structure which is formed by the union between the retina and the vitreous. The posterior vitreous cortex, as discussed, around 100 to 300 micron thickness, consists of the densely packed type 2 collagen, which is firmly adherent to the type 4 collagen of internal limiting membrane. Between these two is the extracellular matrix glue, which is composed of the molecules of proteins like laminin, fibronectin, proteoglycan. They form a gel-like substance in interaction with opticin. The vitreomacular junction has an annular shape with a diameter of 3 to 4 mm. With age, there occurs the changes in the vitreoretinal interface. There is a gradual destruction of collagen hyaluronic acid, leading to the loss of interfibrillar hyaluronan and leading to weak vitreomacular adhesions. This weakening causes the posterior vitreous cortex to detach from ILM, known as posterior vitreous detachment. The complete PVD is defined as a complete and the clean separation between the posterior vitreous cortex and internal limiting membrane. The vitreous liquefaction starts at the age of 2 years, and with the increasing age, larger and the more pockets of liquefaction take place. When the liquid vitreous enters the retrocortical space via the prepapillary hole, there is a large volume displacement from central vitreous, which causes the collapse of the vitreous body and leading to progressive weakening of vitreoretinal adhesion. The rotational eye movements plays a dynamic role in increasing the size of PVD as the liquid vitreous dissects through the plane between the VRI. PVD can be a normal process with aging, or other predisposing factors can be trauma, refractive errors, particularly myopia, intraocular surgery, some inflammatory processes, and physiological decreased levels of estrogen in postmenopausal women. The stages of PVD. In the stage 1 PVD, there is perifoveal detachment of vitreous. In the stage 2, the vitreous is attached to the optic disc and mid-periphery but detached from the fovea. In the stage 3, it remains attached only to the optic disc. And the stage 4, which is known as the complete PVD, it is completely detached from the retinal surface. The anomalous PVD is the anomalous separation of the vitreous cortex from internal limiting membrane and can lead to an abnormal vitreoretinal interface. This anomalous separation can either be due to the liquefaction, which occurs faster than detachment of vitreous, or abnormal adhesion of vitreous cortex to ILM. Faster liquefaction is seen in diseases like Marfan's, Ehlers-Danlos, and Sticklers, while abnormal adhesions are seen in diseases like diabetes. The anomalous PVD can lead to a full spectrum of diseases in ophthalmology like macular hole, macular pucker, vitreomacular tractions, traction retinal detachments, vitreopapillary traction, and retinal tears and retinal detachment. For today, our interest is limited to the anterior-posterior traction at the macula and VMT. The pathomechanism of VMT includes a static and dynamic vitreous traction. The static traction can either be anterior-posterior or tangential, while the dynamic vitreous traction is due to the ocular movements through which, as described earlier, the liquefied vitreous moves and enlarges the PVD. The foveal deformation depends upon the size of the vitreomacular adhesion, the strength of the VA, and the depth to which the surface directional forces are transmitted within the retina. The histopathology of VMT from the specimens obtained intraoperatively have shown that it contains cellular types like astrocytes, myofibroblasts, fibrocytes. If the retinal pigment cells are also present, then it goes in the favor of epiretinal membrane. So first of all, vitreomacular adhesion. The IVTS had defined VMA as macular attachment of the vitreous cortex within 3 mm radius of the fovea without any detectable changes in the retinal morphology. The posterior vitreous face is not completely detached from macula. The IVTS study group had classified on the basis of OCT as focal and broad adhesion. The focal adhesion is less than 1500 microns and the broad adhesion is more than 1500 microns. Generally, with VMA, the patients are asymptomatic, as it does not cause any apparent retinal changes. It is a part of the natural component of development of PVD and generally does not require any treatment. The clinical course can either be, it can remain stable or undergo a spontaneous resolution and form a complete PVD, or it can undergo a full vitreomacular traction. The next is vitreomacular traction. The IVTS defined VMT as excessive traction on the macula from vitreous that changes the contour of foveal surface and usually causes the symptomatic loss of visual function. This image shows how the taut posterior hyaloid attached to the fovea can cause a change in the shape of fovea. The symptoms, patient can either be asymptomatic or can present with decreased vision, photopsias, micropsias, macropsias, metamorphopsia. These symptoms can significantly affect the quality of life of patient. The clinical features, the fovea can have a distorted appearance, blunted foveal reflex is present, some cystic changes can be seen at the fovea, or in severe cases, the subretinal fluid is also present, causing the foveal retinal detachment. With the advent of OCT, there has been a revolution in the diagnosis of the VMT, with the prevalence in the pre-OCT era around 22.5 cases per 1 lakh population, and now in the OCT era increasing around 1,365 per 1 lakh population. The mean age has been found to around 65 to 70 years with predominance in females. The course of VMT, it can either remain stable or can undergo spontaneous resolution, or it can develop to a full thickness macular hole. Spontaneous resolution of VMT occurs in 10 to 35% of cases. IVTS again classified the VMT as focal and broad. Focal is less than 1500 microns in thickness and broad is more than 1500 microns. Focal causes the focal distortion of the foveal surface, it elevates the foveal floor and forms cysts within the central macula. While broad VMT is generally responsive for generalized thickening of the macula, vascular leakage on fluorescent angiography, macular schisis, and cystoid macular edema. Vitreofoveal traction has been described to just central foveal of less than 500 micron. This is the International Vitreomacular Traction Study Group, which we have described earlier, which had described all the definitions and classifications of vitreomacular adhesion, the VMT, and full thickness macular hole. VMT may be associated with a foveal cavitation, leading to formation of cystoid cavity in the inner part of fovea, cystoid macular edema, schisis, which may lead to inner lamellar holes, foveal retinal detachment, leading to SRF and progression to full thickness macular holes, epiretinal membranes, and pseudo holes. Generally, there are two types of traction profile explained in VMT, the V-shaped and the J-shaped. In V-shaped, the vitreous cortex is detached from retina, both temporal and nasal, to the fovea, and attached only to the fovea. We can see here that it is attached only at the central foveal point. And while in the J shape, the vitreous cortex is detached from the retina, temporal to the fovea, but remains attached to the retina, nasal to the fovea and to the fovea itself. V-shaped is responsible for focal VMT, while J-shaped is responsible for broad VMT. V-shape causes the traction CME and full thickness macular hole. J-shape causes the ERM and diffuse retinal thickening. The grades of VMT. The grade 1 includes the foveal distortion. Grade 2 includes the findings of grade 1 plus interretinal cysts. Grade 3 includes subretinal fluid. This is the OCT image describing the grade 1 VMT with showing the incomplete separation of the cortical vitreous with the persistent vitreous attachment at the fovea and ILM with no cystic changes but altered foveal contour. This image shows the features of grade 1 plus interretinal cyst or cleft or schisis. Another image with grade 2. This is the example of grade 3 VMT with the presence of subretinal fluid plus the changes of grade 1 and 2. Another image showing the presence of subretinal fluid. The treatment of VMT includes either observation, pharmacological vitrolysis, pneumatic vitrolysis, or pars plana vitrectomy. The aim of the treatment is to eliminate the anteroposterior and tangential traction, thereby relieving the attachment of vitreous to macula. In a study in which the vitreomacular traction was managed initially by observation, it was observed that around 1/3 of the eyes, around 32%, had resolved spontaneously over a mean period of 18 months. They showed that grade 1 had 23% resolution, grade 2 had 32% resolution, grade 3 had the maximum 70% with the overall resolution percentage of 32%.
Go back to the slide. Can somebody just explain why this should be that grade 1 the resolution is less, whereas in grade 3 there's more resolution? You all know what is grade 1, 2, 3, right? He described that. You can go back to grade 1, 2, 3 in case they miss those pictures. So grade 1 is only foveal distortion. Grade 2 is when there is cystic space or schisis. And grade 3 is there is SRF. Okay. So he's put up a slide showing that in grade 3, the spontaneous resolution was more. 70%. You can just guess any hypothesis you can tell.
Point of attachment of traction will be less, so eventually because the PVD and broader and the pool is in a much greater area compared to the grade 3.
You can tell that. Basically the traction is probably pulling more, and when it pulls more, eventually it's going to get resolved by itself. So that's what it indicates. So the pull is more in grade 3, and because the pull is more, it can also resolve by itself quite easily. Yes, so overall, they got 30%.
Next is the pharmacological vitrolysis. It includes the concept of the enzymatic breakdown of extracellular matrix proteins at the vitreomacular interface to release the adhesion. It was first described in 1998. There were a variety of enzymes which have been described till date, like collagenase, chondroitinase, hyaluronidase, dispase, nattokinase, plasmin, plasminogen activators, but most agents have been abandoned till today due to the toxicity and the insufficient clinical efficacy. The ochriplasmin has been the first-in-class pharmacological agent to manage VMA or VMT without surgical intervention. The microplasmin is the truncated form of plasmin, and the ochriplasmin is the recombinant human serine protease microplasmin. It has got proteolytic activity against laminin, fibronectin, and collagen, which form the extracellular matrix glue. It induces the vitreous liquefaction and causes the separation of vitreous, thereby leading to PVD and the release of vitreous traction. Commercially, it is available in the form of Vitreo, and it had approved FDA approval for the treatment of symptomatic VMA and full thickness macular hole less than 400 microns in October 2012. The dosage is 125 micron per 0.1 ml. Since 2015, the readily diluted form was also available. There have been various clinical trials on ocriplasmin, namely MIVI Trust, Oasis, Orbit, Inject, and Ovid 1 and 2 studies. The MIVI Trust study was the first major clinical trial on ocriplasmin. It involved the two parallel multi-center randomized phase 3 clinical trials. The aim was to compare a single intravitreal injection of ocriplasmin with a placebo injection in patients with symptomatic VMA. Primary endpoint was described as the resolution of VMA at 28th day, and the secondary endpoints discussed were total PVD, non-surgical closure of macular hole, avoidance of vitrectomy, and the change in the best-corrected visual acuity. The study involved a total of 652 eyes, with 464 eyes being treated with ocriplasmin and 188 with the placebo. The vitreomacular adhesion resolved in around 26.5% of the ocriplasmin-treated eyes as compared to the 10% of the placebo. Even the incidence of total PVD and the non-surgical closure of macular holes was higher in the eyes treated with ocriplasmin. The visual acuity was more likely to improve by more than 3 lines with ocriplasmin than with the placebo. Fewer patients had to undergo the vitrectomy at the end of 6 months. Although the ocular adverse effect profile of ocriplasmin was higher than the placebo injected, but the serious ocular adverse profile was almost similar. The post-hoc analysis of the study showed that there were some positive predictive factors for the successful release of VMT by ocriplasmin, which included a focal adhesion diameter of less than 1500 microns, the absence of ERM, the phakic status of the patient, and the age younger than 65, and macular hole of less than 400 microns as compared to larger macular holes.
Yeah, go back. So any guesses why a phakic patient or a younger patient should have better resolution of VMT with ocriplasmin? You would expect a pseudophakic eye or an elderly patient to have better resolution of VMT, right, with any treatment. The other points are right. When there is epiretinal membrane, there's going to be more adhesion, so the release of VMT is going to be difficult. And when it's a larger adhesion, again the VMT release is going to be difficult. But these 2 points, phakic status and younger age. So what they told in this analysis was that the patients who had phakic or younger resolved better, whereas pseudophakics who had VMT actually had more stronger VMT. That's why they had VMT in a later age group or in a pseudophakic eye. Usually a pseudophakic or a elderly patient would have resolution of the vitreomacular adhesion by that time. But if they had some adhesion at that time, it means that it is a very stronger adhesion which is present at that age. So that's why it was not getting released by ocriplasmin. So this is the explanation given by the authors.
Then later on, there were many studies like Oasis, Orbit, Ovid studies, which compared the successful rate of ocriplasmin injections. They showed that the rate of success can increase from 26.5 to around 47 to 49% by the time of 12 months, just that they highlighted that the need for careful patient selection for the injections.
So basically, the later studies compared to MIVI Trust, they selected those patients which had a better resolution with ocriplasmin. The inclusion criteria, they changed actually for the later studies. Initially, the first MIVI Trust study, they included all patients with VMT. And from that, they found out which patients had better resolution with ocriplasmin. And they recruited only those patients in the further studies. So they got better results in that subgroups.
In an innovative technique in which the OCT guided injection was given, of ocriplasmin was given near the surface of macula, it showed that the higher resolution rates were achieved as compared to the normal ones.
Go ahead.
There is a full large adverse effect profile of ocriplasmin, which has been described as acute ocriplasmin retinopathy. It includes the side effects of vision-related, like photopsias, vitreous floaters, dyschromatopsia, reduced visual acuity, the loss of contrast sensitivity, dark adaptation difficulty. The ocriplasmin can also digest the zonules of the lens and lead to subluxation of the lens. Or there can also be the worsening of the macular holes. Some injection-related side effects like subconjunctival hemorrhage, retinal hemorrhages, breaks, retinal detachment, and ophthalmitis, increased intraocular pressure. The OCT showed the ellipsoid zone disruption and accumulation of SRF within the first 4 months of injection. The transient ERG changes in the first month of injection were shown, like decreased amplitude of A and B waves. Even the resolving VMT showed like optic disc morphology in which the decreased cup to disc ratio was present.
So the complications, what they told was where they were transient, and they were because of the development of the PVD actually. So if you see most of the complications, they tell floaters, photopsia, which are all a part of the PVD induction process. So they tell that they are transient and the usually vision is not affected. So that's what the studies tell. Yeah.
However, the cost of ocuroplasmin has been a major concern regarding the usage of this drug. A single injection causes approximate $4,000, and the cost per quality life for compared quality-adjusted life years compared to vitrectomy is almost double for the ocuroplasmin as compared to vitrectomy. So this injection was reserved for the patient who were symptomatic but are unfit to go for surgery, like but should have been ideally like phakic patients and having the small macular holes. The next is pneumatic vitreolysis. The injection of an expansile gas into the vitreous cavity can also cause successful PVD and the resolution of vitreomacular traction. Overall, the studies have described 40% chance of VMT release with the gas injection. The benefit is that it has low rate of adverse events, low cost, and it sounds a feasible alternative to the surgical management. But there is no level 1 evidence related to gas injection for the use of in the vitreomacular traction. In a case series of 30 eyes who were with vitreomacular traction, on whom the intravitreal C3F8 injection was tried, they showed approximately 83% of the eyes had final release rate, and the benefit was that there were no side effects related to injection. In fact, any injection in the vitreous can cause posterior vitreous detachment and release of VMT. Lastly, the surgical management of VMT. The pars plana vitrectomy is the standard procedure for the release of VMT, and it causes the mechanical release of vitreous attachment, sometimes coupled with ILM peeling. This approach has shown to improve the visual acuity and anatomic configuration in multiple studies. Nearly 100% resolution of VMT have been achieved by the surgery. The indication for the surgery in VMT include the patients presenting with decreased visual acuity, having severe metamorphopsia, the patients who fail to improve with observation or have a demonstrated progression of traction defects, or VMT associated with ERM. Although no consensus on level of visual acuity has been considered as significant, but usually the symptomatic involvement is taken as an indication for pars plana vitrectomy. Some poor prognostic factors for the surgery for VMT have been described, like maculocysis, prominent CME, chronic retinal detachment, premacular fibrosis, VMT of duration more than 6 months, thicker central macular thickness preoperatively, and poor pre-op visual acuity. Pars plana vitrectomy can be combined with other procedures like stripping of the posterior hyalid, ERM peeling, ILM peeling, air fluid exchange, or gas or air tamponade. In a systematic review and meta-analysis of pars plana vitrectomy for vitreomacular traction, they involved around 21 studies, and they showed that nearly 64.3% of the patients had improved visual acuity post pars plana vitrectomy. Although they had a safety profile questionable, like the cataract was found in 35% of the patient, epiretinal membrane and retinal detachment were the other side effects. In another study which compared the resolution of VMT after ocuroplasmin or vitrectomy, they found that even though the injection is a less invasive technique of releasing of VMT, but its weight should be compared to the vitrectomy rate because of the morphological and the side effects of ocriplasmin. The complications of surgery include the cataract, residual epiretinal membrane, progression of full thickness macular hole, lamellar macular hole, persistent CMEs, persistent subretinal fluids, macular atrophy, retinal breaks, retinal detachments, RPE damage, the visual field side effects, glaucoma, and of hypotony, bleeding, and always the anesthesia-related risks. VMT can be related to other retinal pathologies, like, first of all, epiretinal membrane. ERM is the cellular proliferation that creates a semi-translucent fibrocellular proliferation of the surface of inner retina. It appears in OCT as a hyperreflective layer on the surface of inner retina. You can see the topmost hyperreflective layer. The pathogenesis of ERM involves that the PVD may create small dehiscences in the ILM through which the fibroglial cells migrate and proliferate over the inner retinal surface. The residual vitreous collagen serves as a scaffold for the cellular proliferation and forms a more adherent ERM. The formation of ERM leads to the formation of tangential tractional forces on the retina, which contain the cellular contractile elements, which may cause distortion of the retinal surface, retinal folding, macular thickening, blunting of the foveal contour, or even pseudocyst formation. In patients with VMT associated with ERM, they found that they had a poor spontaneous resolution. Poor resolution was seen even with the ocrioplasmin, and the only way of management left was surgical intervention. VMT and relation to diabetic macular edema. OCT has been an important tool in evaluating the tractional component of diabetic-related macular edema. In the VMT associated with DME, poor response of resolution of macular edema has been seen to anti-VEGF injections because it causes the enzyme-mediated vitreous collagen cross-linking plus non-enzymatic vitreous glycation, which causes the destabilization of vitreous gel and causes a stronger VMT. Vitromacular separation in these cases leads to resolution of DME. These cases are only highly responsive to vitrectomy. In the age-related macular disease, eyes with VMA or VMT shows less improvement in best-corrected visual acuity after anti-VEGF injections for wet AMD. The pathogenesis described is like VMT may cause a barrier effect to the drug delivery to the posterior pole. It was found that the fewer anti-VEGF injections were required for the eyes who were earlier treated for ocrioplasmin for wet AMD when the anti-VEGF injections were given. So, in the summary, we state that understanding the role of vitreous in VMT helps us in tackling it in a better way, and OCT has helped us in a long way to describe, classify, and understand the vitromacular interface in a better way and the abnormalities related to it. So here is a flowchart which we can follow while managing a patient with vitromacular adhesion or traction. As a summary of this presentation, if a patient presents with the vitromacular adhesion, we can observe the patient for a particular amount of time. And when it develops to a vitromacular traction, patient, if asymptomatic, can again be put for a follow-up for every 3 months. Or if symptomatic and not associated with any other retinal macular pathologies, can also be observed. But if the patient is symptomatic and has associated macular pathologies, he can undergo intravitreal injection or can ultimately go for surgery. So currently there is no published consensus regarding the guidelines for the management of VMT. Patients can be observed for 2 to 3 months to see if spontaneous resolution occurs, although this is dependent upon the symptom severity and the impact on the individual patient quality of life. If there is no resolution, treatment should be considered, taking into account the prognostic factors like width of the VMA, patient age, presence or absence of ERM. Ochriplasmin is not available in India, and the worldwide popularity has also decreased. Surgery is the definite treatment for VMT, and if in any case patient is found unfit for the surgery, we can try pneumatic vitriolysis. A few cases for discussion. There was a 58-year-old female presented to the OPD with blurring of vision in right eye for 3 months. The best corrected visual acuity was 615 and N10. The IOP was 19 mm HE, and anterior segment was within normal limits with clear lens. Her OCT image was like this. First of all, I can ask any PGs to describe the OCT image. It's for the consultant, like, but how should we approach for this patient?
You first tell them the grade.
Then you name the consultant. You
Tell all
name
that
the
first.
yeah.
Then we talk about the treatment. You have given us only half the information, so I can't give you the treatment.
Well, you name the consultant.
Yes, sir. First of all, for defining this, we need to go it layer by layer for describing the OCT. Shall I only?
You only, yeah.
So this is the OCT image showing that the abnormal foveal contour with the increased retinal thickness can be seen. The hyperreflective lowermost RPE brush memory complex is intact. Then the cystic spaces can be seen with the full separation of the retinal layers, just adherent at the innermost retina point, with the presence of cystic spaces, altered layer defects can be seen, and presence of SRF is questionable. Sir, here it can be present also, it can be absent also. Full thickness defect is there.
Now, what is the
Grade 3 VMT. Yes. The RP.
Describe all the layers then.
So the foveal floor is elevated.
Yes, sir. By the pulling up mechanism.
What is this? Why on the other side you cannot see the round? What is the one above that?
This one.
Yeah.
So this is the component of PVD only.
Permanent PVD, so you have to double.
Sir, that was what's anomalous PVD is there, like it is not a complete clear PVD. Anomalous PVD does not occur at the clean margin. There is always some margin of so this patient was diabetic. No, the only diabetic patient was. No, sir, like if it was a clear PVD, it would have separated completely and this layer would have been absent. Normally, most of the clean PVDs, even the clean PVDs are not clean PVDs, theoretically. Because there are always some cells which are adherent to the vitreous cortex on the ILM.
I don't think
This one.
We induce the PVD in this case, we are going to de-roof that area into a full thickness macular hole. So if we are planning surgery, do we plan it along with an ILM peeling?
Good observation. There is a risk that it can get de-roofed and the patient may develop a full thickness macular hole. Explain to the patient and you need to be prepared. So if that happens during surgery, then you go ahead and
And these are the cases. Typically, if you want to kill ILM, you can time even ILM also having the same risk. So, macular sparing, ILM peeling, what we talk about, we peel a little bit around but leave cap of the macular hole intact. But Vikas was talking about symptoms, even if you remove all the retraction. But what we need to tell them that because retina, the wrinkling, everything to settle down, sometimes it takes, even they are reported up to 9 months. So progressively vision will start improving, far better off than what pre-surgery. But vision will be better, but symptoms to relieve, you have to tell them that is going to take a very, very long time. On an average 6 months, but up to even sometime 9 months. But progressively they will see that distortion is reducing, subsequent follow-up, if you keep on check, asking them, eventually they settle down. Vision, again, never come back to almost normal. It generally settles down somewhere in between normal vision and pre-surgery vision. So suppose I have 6/18 vision, somewhere they'll improve between somewhere around 6/9 or something, 6/7.5, not exactly 6/6. So compared to other eye, it will be always relatively marginally less. If 6 is there, he comes somewhere around 6/18 or so, not 6/9 or 6/6. Goes well. That also need to be explained. It's not like that you remove the ILM and everything is fine. Has been again not reduced popularity. It will never got popular. It was never gained popularity at all because cost is huge. Success rate is almost around 28% in upperclassmen group and placebo is 10%. So effectively difference is only 16 or 18%. Not really much difference in that. So it never took off actually. And the huge list, what you are rightly mentioned about huge list of complications. Okay. So except manufacturer and people those are directly involved in a trial, hardly anybody use Oct Image. They tried their best every trial, everywhere, all the presentation everywhere. And as you rightly mentioned, it is most of the places it's not even approved also. It is not obviously available. So when you put a flow chart, the flow chart you want people to take is a realist, like that's a take-home message. So when you know Oct Image is not available in India, don't put it in our Indian context.
Yes, sir.
So given scenario, in our scenario, best option is if patient is symptomatic, surgery. Spontaneous relief of ERM, spontaneous relief of restriction is only less than 5%. Effectively 1 to 2%, definitely less than 5%. So if patient is symptomatic and progressive worsening of the symptom patient comes back, irrespective of vision, what you rightly mentioned again, that is the indication for surgery.
The next case, a 77-year-old female presented with complaint of blurring of vision in the right eye for 2 months. The best corrected visual acuity was 6/12 and 10. The anterior segment showed grade 2 nuclear sclerosis cataract. And this was the OCT image for the patient. It shows that even the anatomical and morphological changes may be present, but still our observation for this patient underwent phaco with IOL and post-op visual acuity was 6/6 and 6, and patient had no complaint even of metamorphopsia.
And also, what is her educational qualification? Yes, patients who have well read, well learnt everything, they'll probably be unhappy even after you do a good surgery and a good anatomical resolutions.
The third case, a 60-year-old female presented with a complaint of left eye diminution of vision for 3 months. Her best corrected visual acuity was 6/12 and 6, and anterior segment again showed grade 2 nuclear sclerosis cataract. And this was the OCT image. Little bit foveal contour distortion with SRF is present.
And pull this bowing of the.
This patient underwent phaco with IOL and post-op visual acuity was 6/9 and 6, but still an unhappy patient.
Got unhappy, happy? No, it's written in the file chart, huh?
No, sir, not written in chart. It's just that who are post-operatively unhappy with.
No, it's written in the case.
Not written.
Did you give a questionnaire?
Achha, you put it yourself.
That's all for me.
Very good class, Sushant.
Thank you.
And you've put in a lot of efforts to get all those images from the OCT room and show the different grades. So well done.
Thank you, sir.